And then a lot of tongue tumors. I mean, I had one a week and a half ago or so that was more than halfway back or so, but in a patient who's got good mouth opening, and especially if they don't have teeth, it makes it even easier, and we can get back there pretty well just looking directly. This shows actually something that most people don't do anymore. In the past, folks used to use what they call a tongue flap. So this is the tissue they were removing, and then they took another wedge of tissue out of the central part of the tongue, and once they removed the cancer, they moved that flap of tissue over. And it seems good, and hey, it's natural tongue tissue, but it really makes for more scarring and tightens things up. So in a lot of cases, if it's too big for us to just close, in other words, if by suturing things closed, we make them tongue-tied, limit their tongue mobility, we may either put a skin graft on or an alloderm graft, a tissue substitute basically. I don't generally like to do this. You can't even just leave it open to granulate. It takes forever to heal, so that's part of the reason we don't like to do that. Or because we have slick free flap surgeons. I'm not one of them, that's why I can say they're really slick. Doing something like a radial forearm free flap sounds like a big deal, but I mean, they can do that in a few hours, or it only adds a couple hours onto the case. So this just shows a picture. Since I don't do that, I don't have great videos or anything with transoral robotic surgery. Ironically, I mean, this is just removing a tonsil, so not all that different from what we would see just looking indirectly, but you can see the angle is a little bit different. This is the endotracheal tube and the epiglottis here. So certainly if you've got a sizable tonsil tumor that's going way down, down into the lower oropharynx, we can't really see that looking indirectly, so the view you get with transoral robotic surgery is better. It really depends on experience, training, and such. So I mean, in high volume centers, they really push the envelope on this, but usually, I mean, I know Dr. Candle is more stage 1 or stage 2 tumors, a little bit smaller, and then it just depends on the location. If it's limited to the tonsil, it's not bad. If it's more so on the base of the tongue, it's not bad. Anything that's big, that's going off into the throat tissue on the side, it gets harder to do that safely because just past the side wall of the throat is the carotid artery and the jugular vein, so that increases the risk substantially. And then just big open approaches to get to larger tumors, and in a lot of cases we'll do, as it says, a mandibulotomy, so we basically make a cut in the mandible so that we can open things up really widely and get way back. I don't want anybody to lose their lunch. And then if we have a cancer that's involving the mandible, then we do just slightly different terminology, a mandibulectomy. So we'll cut the bone, obviously, where we need to remove it, and that gives us exposure to get back in, or to get in there. More often than not, if we're removing a chunk of mandible, we'd either be putting a plate or they'd be doing a free flap to replace that. And then this just kind of shows me, this looks horrible, but I kind of like the progression so that you can see when he's closed up, at least on the outside, he really doesn't look too bad. So this gentleman had or basically has, because he's still around, a skin condition, scleroderma, like all of his skin is just very hard. And he kept going in to see the rheumatology folks that he was having more trouble speaking, and they thought he was having some kind of immune inflammation of his tongue, and it turned out to be a cancer. So it was involving most of the front half of his tongue, floor of mouth underneath the tongue, and going to the jaw. So he had the central segment of his mandible removed. That's end of mandible here, end of mandible there, and then what's in back is maybe the back third or half of his tongue. So in that case, they actually did use a pretty sizable, at least I think that was the case, a pretty sizable fibula flap, and when they removed the fibula flap, they also had some of the skin and muscle over it. So what you're seeing here is the soft tissue over the fibula. On the fibula, the bone itself is underneath, and then we just basically were able to close the lip primarily because this cancer wasn't coming out through the bone into the lip. So once again, I mean, you see him on the outside and things look fine, but unfortunately that's a big functional change because he doesn't have much movable tongue. So then in these patients, again, it's a much bigger concern, and certainly in these bigger operations where we're intraorally and we're working in the neck, one of our big risks is causing a fistula, which can affect healing and lead to infection. If there's a free flap, I mean, leakage through the suture line into the neck can affect the vessels and lead to clotting of the vascular pedicle and death of the free flap. In those cases, tracheotomy is very common during the procedure. It's good to get the tube out of the way. But if we're doing a smaller procedure, say maybe not a free flap where we know someone's going to need a trach for a while afterwards, then we potentially just nasally intubate during the procedure and they can get extubated afterwards. But certainly for a big free flap, they virtually always get a trach. And then, as I said before, for the concern for leakage and fistula formation, most of those patients are NPO for a good couple weeks. And really the two issues afterwards, we want to make sure they're healed so that everything is watertight, but then we virtually always have speech therapy involved to see, if we're taking out a portion of their tongue, we've got to make sure they're not at high risk for aspiration. So 2 weeks minimum just to allow healing, and then, if everything looks good, we'd at least get a speech path consult or get a modified swallow and do that. Things have changed a little bit, but with, say, a major oral cavity or pharynx resection, in general, people would be in the ICU maybe a couple days, and even if especially if they've got a trach, we know their airway should be secure. The free flap adds a lot to it, and just for the need to monitor the free flap closely and check pulses on an hourly basis, patients end up being in the ICU for the better part of a week. So, and I know where I came from, we had a sort of a specially set up step-down unit where we had higher number of nurses for a small unit that was only 4 beds, and they were doing like the hourly flap checks there. Because in a lot of these patients, other than the flap monitoring, they don't necessarily have a lot of critical care needs. But here, that's the way we've been doing it. They're just very conservative in that regard, just to make sure they're getting watched close and everything. So that might be something that may change down the road, but that's where we are now. And then a lot of these patients, depending on their home environment and obviously their needs afterwards, may need placement and at very least some assistance at home. So I won't really dwell on this. A lot of different issues that can come up afterwards. I guess we've got plenty of time. Any other questions now? Everybody's asleep.
I guess with the drains, what type of drainage are we expecting, and what do we start to freak out about?
So that's a good question. So if we look at those patients, neck dissection, it's really chyle, but in those patients, it's looking at the trend. Oftentimes, right from the get-go, it should be less than 100, and then pretty quickly, over a day or so, it becomes more serosanguinous. But then, just drainage looking more junky can suggest that there's saliva draining down, or if it just looks more frothy or so. And going back to the issue of chyle, in patients who are on tube feeds and maybe not having a regular diet, certainly, and not getting as much fat, sometimes it's not as clear. It may not be white milky drainage coming out. It may just look more fatty and kind of bubbly. So those are the things to look for, just that quality change. And then chyle, if it is still somewhat more serous, can be a bit more yellow than your average serous fluid coming out. So the larynx, not to dwell too much on the anatomy, but the thyroid cartilage in the middle, making up the most prominent structure, the Adam's apple as we think about it. And larynx really goes from the cricoid cartilage here, sitting on top of the trachea, up to the hyoid. And you can even see the epiglottis, still considered part of the larynx, goes up even higher than the hyoid in space. And then looking from the back, we talk about the 2 different sets of vocal cords there. What we speak with, the true vocal cords, and then above those are what are called either the vestibular folds or the false vocal folds. And they're basically just extra folds of tissue that help close things off to assist with airway protection in the swallow. And then in between the two is the space called the ventricle, that just basically a lot of glands there that make some of the mucousy secretions that help lubricate your vocal cords. So this just shows an endoscopic view, which I'm sure Dr. Moore did before, but it's a little bit harder to see in 2 dimensions as you're looking down, but the true vocal folds coming more medially, and then that ventricle you don't really see much, you just sort of see the line, and then these are the false vocal folds on either side above that. So anything sort of from above the vocal cords, so false vocal cords, the arytenoid cartilages back here that the vocal cord connects onto, the epiglottis here, that's all considered the upper part of the larynx, the supraglottis. And then below the vocal cords is the subglottis, and then the vocal cords, that level itself is called just the glottis. So we talk about the 3 different levels of the larynx. So as far as getting to laryngeal tumors, depends certainly on size and other considerations, but an earlier tumor, as this shows, we can just go in with a laser and remove that. And as you might guess, I mean, normal vocal cord there, this crater that's caused by that, you'd expect that to have a pretty big effect on their voice. So in most cases, we wind up treating these patients with radiation. This is very early. That's a stage 1 tumor. So radiation dose isn't huge. They don't need chemo. So it's still a lot to go through. But in most people, the functional outcome is a little bit better. And certainly somebody who comes in with a tumor like this, even though it's not very big, it's a very different shaped vocal cord. That tumor is going to interfere with how the two vocal cords vibrate together, and that will interfere a lot with their voice production. So sometimes they come in sounding so bad. If they go from this to this, they may even sound a little bit better when things heal. But by and large, most of the time we end up treating with radiation. So this just shows what's involved in a total laryngectomy. Now, there's a lot of different flavors of laryngectomy, removing parts of the larynx. We don't do that much of it. Some of that is just based on the fact that many of our patients who have laryngeal tumors do get radiation and or chemo first. So if someone recurs after that, then we'd be doing surgery, and more often than not, we kind of have to take out the whole larynx because there's a lot of scarring from previous radiation. If we take out part of the larynx, their function will be really, really bad. So they may need a trach, they may need a G-tube, and as odd as it is to say this, someone who still has their voice box and has a trach and a G-tube is usually a lot worse off in quality of life than someone who doesn't have their larynx and can eat normally and can speak in different ways that I'll get into. So this just kind of shows the skin flaps lifted up, and then we separate the lobes of the thyroid, so your larynx being in the middle. We just separate all the muscular attachments, divide the trachea down low. That just shows the larynx. Yay. And then once the larynx is removed, in this picture, I mean, the stoma where the trachea is down here, so the endotracheal tube is going up off to the side. This is kind of the opening of the cervical esophagus going down, and then this is what's left of the pharynx behind where the larynx was just removed. So in most people, especially if someone hasn't had radiation before, there's enough pharyngeal tissue that we then just stitch that closed, and that forms a tube. So afterwards, well, another slide down the road. So post-op, because we need the pharynx to heal, these patients are always NPO. People differ as far as how long they'll stay NPO, but here, most of us are about a week to 2 weeks or so. Someone who hasn't had radiation, if everything looks like they're healing very well, in some cases we'll just start them on liquids and see how things go. Most of the time we'd lean towards just getting an esophagram so we know 100% that there isn't any leakage. Speech pathology, in most cases, hopefully has even seen these patients beforehand so they can start talking to them about stoma care and about speech options afterwards. Most of them will have some form of tube in afterwards. And that's why it's very important to know what surgery they had. That, if someone had their larynx removed, this is their only breathing passage. So it can be a little bit confusing because you can't really tell on the outside if somebody has, as it's called in a laryngectomy tube, and a Shiley LGT compared to like a regular Shiley cuffless tube. So, and I'll get into that a little bit more, but we've had disasters where, a code was called on a laryngectomy patient, and the anesthesia resident is trying to intubate through the mouth and they can't find the airway for obvious reasons. So some of the other tubes that we've gone to using more now, these are what are called Larry tubes, and they're basically just softer. They're easier for the patient to tolerate. And in the initial healing phase, it's a little bit dogma. I can't say there's science behind it, but because it's softer, a little bit less likely to irritate the suture line around the trachea and cause problems. In some cases, we don't really use this immediately afterwards, but later on, we'll use what's called the heat-moisture exchanger. So it's a cap that can go on these Larry tubes. And patients who've healed will sometimes use it with an adhesive disc, as this shows. So the adhesive disc sticks onto the skin around the stoma. There's a plastic rim to it, and then the heat-moisture exchanger, which I'm sorry I didn't have an extra picture of, it just plugs into that. So it's essentially a cap that has a foam in it, and just breathing through that, it gets saturated with moisture, so it replaces your nose. Because when you're breathing through your nose, by the time the air reaches the back of your throat, it's already warmed to body temperature, it's moisturized. Whereas if you're breathing directly through a hole in your neck, you've got winter air going directly into your trachea, so that by the time it gets down to your lungs, it's still dry, and it's going to dry things out and irritate things. So this helps with that. And I said this picks up moisture. It also, that moisture is going to be warmed up to body temperature by your breath. So it helps for both of those roles in warming and moisturizing the air.
How are those secured in trachs you have like the ties, but like the Larry tubes? We've had patients in the past, they've fallen out.
So it kind of depends on what the situation is. And
Okay.
anyone who's had a flap, we don't like to have any ties around the neck. So that's why sometimes they'll just be laid in there, or we may use the Velcro trach tie and just put it on their chest and tape it on. Most of us, like a week after surgery, if there's a flap, we'll go to a Velcro tie and use that. Again, we don't use these in the hospital much, but you can see the Larry tube has these little eyelets on that you can hook the tie onto it. They have other devices. It's basically just a stick-on patch that goes on either side, and it's got a Velcro on that can then stick to this. I think it's easier just using a Velcro tie, but it's another option because some people don't like to have the tie. But right afterwards, it's either a Velcro tie, or if there's a flap, then it may just be somewhat precarious, but it's easy enough to put them back on.
I was going to say, is there anything specific that we need to know as far as if it were to come out, what do you do next?
Well, in most cases, it would just be simple enough to slide it back in.
Okay.
And yeah, since you brought that up, if we're very concerned, like there's a lot of flat bulk or tissue swelling around the stoma, that it's not a very secure situation, then we'll virtually always just suture it in, just like we would do with a trach tube, a regular trach tube, if we don't want to have ties around the neck.
Is it a situation like with trachs we should have an extra one at the bedside?
Generally, we try to send them up from the OR with an extra trach,
Okay.
usually an extra trach one size smaller. But these are, I'll say, optional. So it's not like we're depending on a Larry tube to hold the airway
Okay.
open. So, but definitely with a Shiley tube, and we'll more often use the laryngectomy tube if there is a lot of edema, because that is more rigid, whereas these are easily compressible. So then voice rehab. Have you guys had experience with any of these?
I don't think so.
So virtually all of our patients, well, let me go back. So what does your larynx do? Your vocal cords just vibrate. Now obviously you can change pitch of your voice and such with your vocal cords, but it's really your mouth and your throat that makes the vibrations from your vocal cords into words. So we need some way to replace those vibrations. So virtually all of our patients right after surgery, we had to use an electrolarynx, and that works two different ways, and I don't have a picture the other way, but it's just this small cylindrical device. You hold it up to the side of the throat and hit a button to turn it on, and it vibrates and makes sound waves in your throat, and then the patient will move their mouth, their tongue, and speak that way. That sometimes doesn't work, say if someone's had a flap, or if they've got a lot of swelling in their neck, it's harder for the vibrations to go in. So the other way to use it is with an oral adapter, and there's basically just a cap that goes on the top of the device and a straw that comes out that they hold that inside their cheek. So if anyone still watches South Park, I guess there's some character on South Park that had what they called the cancer kazoo. So that was I don't watch South Park. And then the other way that a lot of our patients like to move to, if they can, is what's called the tracheoesophageal puncture prosthesis. And that's basically just a little one-way valve that goes from the back wall of the trachea into the esophagus. And it's one-way valve to let air go from the trachea back. So the patient takes a breath in, fills up their lungs, puts their finger over their stoma to block air from coming out, and then as they continue to try and breathe out, it forces air through the prosthesis. And as the air is going through the prosthesis and into the esophagus and pharynx, it causes the throat to vibrate. It's not that different from the little kid at summer camp who could burp the alphabet and everything. You're belching, you're causing vibrations in your esophagus, and then you speak that way. So I've had many patients wanting to do that because it is a little bit more of a natural sound. The downside of it is that prosthesis wears out in 2 to 4 months and then has to be replaced. So initially we put it in the operating room. most of us like to do that after they've completely healed from their laryngectomy and after they've even had radiation if they're going to have that. And basically you need to have a decent sized stoma so that we can get to it to put the prosthesis in so that it's going to sit right. And once it's put in and it heals, then our speech therapists change them in the clinic. So that's